Okay, dear friends, so very simple for me because my talk today is, the title is this one, but I am the very lucky man. In 2017, I invite this guy, Professor Jean-Michel, and this guy worked for me. These three slides, okay, I take his conclusions, shows very good what is now the actual status in order to do gastrectomy for cancer. Many studies showing the advantages, the no problem in order to do the distal gastrectomies, but for total gastrectomies is not totally very good defined. And for this, it is better to enroll different patients in order to start the other prospective randomized studies. And for this, I change my talk today, and I prefer to talk to you about the current aspects of laparoscopic surgery. This is the enemy. The enemy today, including in the Western countries, these cancers, deadly, very high. This is a real killer cancer with a very bad prognosis. And today, for the patients operated in order to healing, the 5-year survival is just around 27%. Why? Because gastric cancer is the systemic disease. And today is totally absurd to consider just a surgery in order to treat this cancer. Multidisciplinarity is a reality today, and for the T2 and positive preoperatively, work just with surgery is totally aberrant. Neoadjuvant chemotherapy improves survival, and these conclusions are totally published today. Another point of view, very important, is consider the preoperative nutritional status of your patients, because with this manner, after your surgery, the patients have the improved results, the outcomes with the real decrease in postoperative complications. Dear friends, today, around the world, in order to treat the gastric cancer, many surgeons prefer the 6th road. The 6th road is laparotomy. It's not laparoscopy. After the pioneers' time and the first series published, maybe associating the development in laparoscopic technicity and the experience obtained by the surgeons in obesity surgery, the more and more around the world, surgeons take laparoscopy in order to treat oncologically the gastric cancer, including in the very adverse patients like this, obese with the prior laparotomies, etc., with real success, including robotic, is for the moment in the movement, and for many surgeons is probably the best one in the future. Why not? Today, for many societies, after past the learning curve, I think about the words of Professor Bergamaschi yesterday. What is learning? It's maybe very important to define before, but after learning curve, for the groups perform gastrectomy by laparoscopy, this study shows the safety, the efficacy, the reproducibility, the less complications, and the same oncologic results at middle and long term. For this, today, laparoscopy is totally accepted around the world. ACOI Italians, NHS in England, Japanese, international journals, etc. This is the real mirroring around the world. But you are surgeons, and the very good question for us is how surgery can improve multidisciplinarity treatment. But I take some examples in order to think about this reflection. The first one is the actual controversies about the when to type of gastroresections. It is preferable to take a total gastrectomy, normally preferred for the upper half tumor location and the diffuse infiltration, or like this, with this type of reconstruction. But the problem is, because the total gastrectomy have in the very good hands the real morbid mortality colligated with the fistulization of the anastomosis, and in the subtotal gastrectomy, this type of complication is not very important. Maybe it is preferable to choose not systematically the total gastrectomy. In the very good hands, the Netherlands group, the Dutch study, shows after the period of the learning curve, the percentage of the fistula after total gastrectomy in their hands is 9%. This is the tag of chaos. Lymphadenectomy is probably the most non-chaotic moment of the gastrectomy for cancer. It's totally very good defined, included, associated with the very severe vascular variations. For what? Because a Japanese group defined very good what is the indication of the D2 over a stage NB for everyone for everybody is necessary to do D2 lymphadenectomy. D2 lymphadenectomy for the Japanese group include the group 10. But by laparoscopy, harvest the 10 station is in many patients very complicated and with the problems. For this, today, for the laparoscopic surgeons, remove systematically in D2 lymphadenectomy, the group 10 is maybe conflictual. About the number of the lymph nodes harvested, 25 is not good. Today is totally proof the necessity to remove 29 or more. And the last but not least, what type of omentectomy? Total omentectomy, partial omentectomy. Well, total omentectomy have, during the intervention, her proper complications. And for the moment, no prospective randomized studies shows the necessity or the oncological utility to remove this very helpful organ. ESMO in United States, NCCN in Europe, NCCA in USA don't recommend total omentectomy associated with total gastrectomy. And for the Japanese group, the indication of the total omentectomy is just for the patient suffering of the T3 or T4 status. For this, in my humble opinion, oblige the surgeon to remove totally the omentum is matter to reflection, and I don't recommend that. And the last is laparoscopy optimized ERAS, the ERAS effect. Today, in order to do the total gastrectomy regularly, it is possible, no drain the abdomen, no put the nasogastric tube, no put the urinary sound. It's possible to do this surgery without a central catheter. The patient don't go in the united car. The patient is mobilized at the first postoperative day, and with the diet adapted, this one is started at the first or the morning of the second postoperative day. Yes, my friends, less is sure, certainly, definitively, absolutely, often more. It's our humble opinion. Thank you for your attention.